So thank you very much for joining us this afternoon for the first of the seminars of the 2025 Research Seminar Series. My name is Alan Hough, and I'm an adjunct professor with the Living with Disability Research Centre at La Trobe University. I'm actually located in Canberra, and I just want to acknowledge wherever we are today, we are, of course, on the lands of Aboriginal or Torres Strait Islander people. In Canberra, I'm on the lands of the Ngunnawal people, and I pay my respects to elders past and present. Just by way of introduction to the technology, if you require the closed captions for this seminar, please remember that there is the closed captions button in your Zoom toolbar. So this seminar is on delivering quality and safe services to people with intellectual disabilities in the NDIS. And the seminar will feature two presentations about the delivery of quality and safe services to people with intellectual disabilities under Australia's NDIS. Firstly, our director, Professor Christine Bigby, will speak about changes in the quality of support in group homes in Australia since 2013. Chris will be drawing on data from the Living with Disability Research Centre's longitudinal study as supported accommodation. Then I will speak about the NDIS Quality and Safeguards Commission applications to the Federal Court for penalties against providers which have caused harm to people with intellectual disabilities. Questions will be welcome at the end of both presentations, and you will note the Q&A button in your Zoom toolbar, so please use that to submit your questions. As always, the slides and the video of the presentation components of the seminar will be available on the LIDS website, probably in about a week or so. But before we go to the presentation by Chris, as some people joining this seminar will already know, we had some great news on Monday. And I know that Chris is probably cringing when I report this, but Chris was appointed an Officer of the Order of Australia in Monday's King's Birthday Honours List. And the citation for that appointment, for that honour, was in recognition of Chris's distinguished service to people with intellectual disabilities, to social welfare and inclusion research, policy and practice, and tertiary education. I'm quite sure that everybody joining this webinar today will join me in congratulating Chris on this magnificent and much deserved honour. So well done, Chris. We're very proud of you. And with that acknowledgement, I'm handing over to you.
Thank you, Alan, and welcome to the seminar. And I just have to say, I think that, you know, research and advocacy is never done in isolation, and all of the work that I've ever done has been in collaboration with industry partners and with colleagues at the university. And I think often it's quite unfair for one person to take credit for, you know, a whole heap of work that lots of people have contributed. But nevertheless, I'm very honoured to receive this award and hope we can use it to further advocacy and research around people with intellectual disabilities. If I could move my slides on, I'd be happy. Okay, so what I'm going to talk about today is changes in the quality of support in group homes in Australia since 2013. I apologise if you were at a conference in Finland where I presented some of this data, and I also presented some of this at the DSC conference a couple of weeks ago. Again, this is work that I'm reporting on, but it's work from our whole team at LIDS. As everybody will know, the NDIS has been going since 2013, and it was fully implemented around 2018. And now it has, or at the end of last year, it had something like 692,000 odd participants, and all the funding has moved from block funding to individualised funding. So in a sense, this data tells us something about the nature of individualised funding and the impact that and the NDIS in general has had on the quality of services. Significantly, and unlike many other countries, funding for disability services in Australia has grown very much since 2011, and you can see the figures on the slide. It's grown from something like 6.5 billion to 42 billion during that period of time in an average year, and it's forecast to keep growing, although they're trying to obviously reduce the rate of that growth. You will all be familiar with group homes, which are often subject to quite differing definitions. However, they're generally called SIL homes or SIL support. And in Australia, as you know, we separate support from housing. Approximately 5% of participants in the NDIS get funding, SIL support funding. But very significantly, they take up 30% of the total funding of the NDIS. So they're a very important small group of people that are very expensive to support within the NDIS. Generally, group homes are described as housing, shared housing for 4 to 6 people who live in ordinary houses in the community. But there's an increasing diversity of design and of size of group homes. So in our study, we're now including services that support 1 person or support up to 6 or 7 people. So it's changed quite significantly over the last 10 years. The largest group of people that use group homes are people with intellectual disabilities. The figures from December 2024 were that 35,972 people were living in group homes, and of those, 39% were people with intellectual disabilities. That's approximately 15% of all people with intellectual disabilities. So group homes are very significant in costs for the NDIS, and they're a very significant service that people with intellectual disabilities predominantly use. They are the largest group of people using those services. And the package size that people have when they live in a group home is much larger than the package for people not living in group homes. But if you look at the average figures, the average amount that people with intellectual disabilities who live in group homes get is $385,700 a year, compared to the average for all people living in group homes, which is $427,600 a year. So there's more people with intellectual disabilities, and on average, they're receiving smaller packages compared to the other people that are living in group homes. That's quite an important thing to bear in mind, I think. So people will have heard me talk before about the research about the quality of support in group homes. There's very clear evidence now that about what makes a difference to the quality of life for people living in group homes. That is if staff use active support, if there is strong frontline practice leadership, if there is cohesive, enabling, motivating culture, respectful culture, and if senior management are supporting and developing policies that support frontline practice leadership and reinforce the quality of practice. Resources are important, but they're necessary but not significant to get good outcomes. We need to have sufficient staff resources, services need to be small, they need to be dispersed in the community, and they need to be in home-like settings. There are lots of propositions in the literature about the impact of the external environment on the quality of support and the quality of outcomes for people living in group homes. Things like the expectations of regulators, workforce turnover, and funding. But there's actually very little evidence and research about the impact of that external environment. And we're trying to sort of uncover some of that, I think. So what I'm going to talk about today is the research questions that we looked at this data using. Has the quality of staff support in group homes changed between 2013 and 2024, which is roughly the period of time that the NDIS has been operating. What other changes have occurred beside the quality of staff support? What's happened to the engagement of the people who are being supported, which is a good proxy for their quality of life? What's happened to the size of group homes and staff ratios? What's happened to the strength of frontline practice leadership? And how can we explain the changes that have happened to those factors and therefore to the quality of what's happening in group homes? So I'm drawing on data, and I won't give you a lot of detail because this has been written and is available elsewhere. I'm drawing on data from our large longitudinal study, and that involves observation of people being supported in their home. We observe using momentary time sampling and a tool called the active support measure. We observe for 2 hours and then calculate the score for the active support measure. We also conduct interviews with the frontline manager and some observation and examination of some of the paperwork that they're responsible for. And staff complete data about the characteristics of the people supported, and staff also complete a survey around a number of things like their experience and their training and the group home culture scale. So what I'm reporting today is 4 data points in our study: 2013, 2018, 2022 and 2024. And the data sets are made up of some of the continuing organisations that have been involved in the study from the beginning, and then newer organisations have joined the study as we've gone along. So there's a mix of long-term organisations and then organisations that have been in the study for a shorter period of time. So what I'm going to report are descriptive trends over time, which talk about the changes that's happened across the whole data set, and then using some statistical tests, talk about some significant differences that we can identify by following the same people or the same organisations or the same services over those different points in time. And we also draw on some of the data from our qualitative field notes. So it's a very rich, and it's probably the largest data set about group home services really in Australia and anywhere else for that matter, that looks at depth about the quality of what's actually happening. So in terms of the findings, they probably won't come as a surprise to people, but they're a bit disappointing. At the level of individuals being supported and at the level of services, so individuals in those services, what we see is a trend of increased levels of engagement for the people being supported from 2013 to 2018, and then a flattening off in 2022 and a drop in 2024. So the average amount of time that people are spending engaged has increased and then has dropped since 2022 to 2024. And you can see that it's dropped differently for different groups. So on average, the blue line, it's gone up and then it's dropped down. For people with low support needs, it's a flatter line and their levels of engagement have remained quite high. And for people with higher support needs, their levels of engagement have dropped more significantly than the people with lower support needs. And those people continue to have lower levels of engagement. So we can see this trend that there's been an increase, so we know what's possible, and then it's dropped off since 2018. At the organisational level, which is counting all the data for each organisation, there is a statistically significant increase between 2013 and 2022. So the average level of engagement went up from 58% of the time to 67% of the time across organisations. And it dropped significantly between 2022, sorry, those numbers down the bottom I've just noticed are wrong. They should be 2018, 22 and 24. They've dropped significantly between 2022 and 2024. So on average now at level of organisations, people are engaged for 62% of the time. That's just over half of their time. If we go back and look at that, people with high support needs are engaged for an average of 46% of time, which is less than half of their time. So people are spending more than half of their time disengaged, doing nothing in group home services. The findings about the quality of support reflect the findings, not surprisingly really, about the level of engagement. So the average level for individuals in terms of the quality of support again went up between 2013 and 2018, and then dropped between 2018 and 22, and for on average and for people with high support needs dropped again between 22 and 24. A good measure of active support is 66%. So you can see that the average for none of those groups are reaching on average good active support. The percentage of people in receipt of good active support has also dropped, and dropped quite significantly. It went up and then it dropped down, and it dropped down particularly for people with lower support needs. And the percentage of people receiving poor active or weak active support dropped, and then it's gone up progressively since 2018. So the story is that the levels of engagement have dropped and the quality of active support has dropped. And it's dropped more for people with higher support needs than people with lower support needs. So how do we explain some of these trends? Contrary to what comes to mind first of all, it's clear that it's not to do with the size of services or to do with the number of staff. There's a very clear trend that the ratio of staff to people supported in group homes has been increasing over time. That means there's more staff to people in group homes over time. There are less people living in group homes, but more staff. So group homes have got on average smaller, and the number of staff in group homes has increased. So we can't explain the decrease because there's less staff. So how else might we explain the decrease? And one of the strongest reasons in our data is the strength of practice leadership. The strength of practice leadership went up very significantly between 2013 and 2018, and then it dropped between 2018 and 22, and it dropped again in 2024. And we know there's a very strong relationship between the strength of practice leadership and the quality of active support. And the percentage of services in our study overall that are rated good or excellent on practice leadership has again increased until 2018 and then dropped significantly to 2024. And one of the interesting things which you should bear in mind, the sort of pattern of the 5 tasks of practice leadership is fairly similar. So they all went up to 2018 and then all have dropped to 2024. But if you just look at this graph, the steepest drop and the most consistent drop has been in terms of allocating and organising staff support. And I think I just want you to remember that, and it may be something that Alan will talk about in terms of risk management processes, because good allocation, good shift planning, good one-page profiles to brief staff, they're a very strong, important element of practice leadership, but they're also a very strong way of managing risk and ensuring that staff are aware of how to support the people that they're supporting on every shift. So how else might we explain, we can explain some of the differences because of the change and the drop in practice leadership, But there's also been a lot going on externally, which may help to explain some of the decline in the quality of support. The raw data shows, and these data, some of this data comes from the NDIS State of the Sector report, and some comes from our study, and I'll just try and make it clear which is which. But the raw NDIS data shows obviously that the value of people's individual packages has increased. It's gone up from an average of about 100,000 to almost 400,000 since the start of the NDIS. But there's been significant increases in the organisational costs that are associated with delivering group home services, which are associated with changes to wages, changes in the awards, and increased costs associated with regulation and compliance requirements that weren't there before, and associated with a very high staff turnover that's happened as a result of the increasing demand for staff and as the NDIS has rolled out. And those things collectively have put together a huge financial strain on organisations. And according to the NDS data at the end of last year, 50% of disability support organisations across the whole sector were in deficit. If we look at our data, it shows a very similar trend for the 19 organisations that we've got data for at the moment. In 2013, all those organisations were showing a positive margin. They were breaking even, or they were making some margin on top of their costs. You can see that progressively the number of organisations that are in deficit has increased. So by 2024, 14 of the 19 organisations in our study were running a deficit, were below the red line on the graph. And they're a mix of medium-sized and large organisations. So they're under financial stress. And some of the other reasons might be, in terms of the external factors, to do with this high level of staff turnover. This data again comes from the NDIS survey, which suggests that there's a 24% turnover of casual staff and a 16% turnover of permanent staff. And that has huge implications in terms of the cost to organisations of onboarding, of recruiting, of training staff. And it has enormous costs in terms of the consistency of support provided, the experience and the skills of staff, and their knowledge of the individuals that they're supporting. One of the smaller studies that we did a couple of years ago really clearly showed, from the perspective of parents of people who were living in group homes, that the thing they were most worried about was the turnover of staff and the uncertainty and new staff coming in who didn't know the people that were being supported. So staff turnover has an impact not only on costs, but on the quality of support. And as I'm sure everybody is aware, there is a huge amount of sector change happening and has been happening since the NDIS has been rolling out. And in the last couple of years, we've had major reviews, the Royal Commission, the NDIS review, the continuing reform now of the NDIS, which has subjected the disability sector and group homes, I think in particular, to significant critique. And it's created an operating environment for services of constant change and uncertainty. And this quote just comes from the NDS report, suggesting that it's a very exhausting operating environment in order to run a service, which is really interfering and meaning that the focus of senior executives is often outward focusing on how to manage the change, rather than inward focusing on how to deliver their core business, which is quality services. As I'm sure everybody is aware too, the cost model for group homes is really flawed. The prices are set by the NDIA, and as one person said in the NDS survey, they're creating a race to the bottom, and the only way for many organisations to remain viable is to compromise their quality. So there is also regulatory strain on disability support organisations because of the administrative compliance-driven approach that's been implemented by the Quality and Safeguard Commission. So that's also a strain in terms of focus and a strain in terms of costs. And what was very clear from our qualitative data about frontline practice leadership was that frontline managers talked about having less time to do frontline practice leadership and to focus on practice because they were spending more and more time on compliance requests, on transaction requests, and on coordinating the often quite fragmented services that were being delivered to the individual people who were living in their group homes. So there's been this sort of focus away from core good practice to managing transactions within the NDIS and managing compliance. And there's also been this sort of diversion, I think, not only from the external change, but a focus away from core business. And organisations are now expected to have lots of nice, what I often call extras, which are not often evidence-based. So the push towards more and more advisory groups, consultation, people with disabilities on boards, all of those things are really good things to have, but they take up a lot of time and energy, which tends to divert focus from the core business of delivering quality. And many of those things don't have a good evidence base behind them, that by pursuing them, you will end up with better quality services. I'm not saying they're bad, I'm just saying they're often a diversion from core business. The other thing I think that explains some of the decrease was clear in the NDIS review. We have a de-differentiated system that doesn't take account in particular of people with intellectual disabilities. And the NDIS review was very clear that the people who had lived in group homes over a long period of time, who were living in group homes when the NDIS came in, were just simply transferred from the previous system into the NDIS system and had been seen as a forgotten and neglected group. That unless they had very strong family advocates, most people just continued to live in the settings where they'd lived before, and there had been no real attempt to find people. Many people are socially isolated, don't have families, don't have advocates, and so there'd been no real attempt to find people, advocates or supported decision makers, to help them think about how they might benefit from the options that were increasingly becoming available in the NDIS about moving out to more individualised settings. And I think, as most of the audience are aware, people with intellectual disabilities are the group that we most rarely hear from and are not particularly well represented in the debates about the changes to the NDIS and the changes to service systems. They tend to be represented by family advocacy groups and by people without lived experience or by long-term service providers. And both families and I think long-term providers have been sort of put to one side as having too many conflicts of interests. And so that's resulted in almost nobody having a voice at the table around the issues for people with intellectual disabilities. So their voices aren't as loud as some of the other groups of people with disabilities. And you can see that from the debates that are happening. They're often around the size of group homes and, in part, as you know from the Royal Commission, the recommendations to close all group homes within 15 years and to shift to individualised accommodation. So the focus has been on housing, on the number of people and on closing group homes, rather than on the quality of support and what's happening for people in group homes, which is important wherever people live. And there is actually very little evidence to suggest that living on your own, if you have a very high support needs, is better than living with one or two other people. So again, we're being driven by things that aren't based on evidence, but that's where the debates are. And even though there was a commitment in 2023 in the own motion inquiry, which was repeated in the Royal Commission. It was repeated in the NDIS review that we should have new practice standards for group homes that focused on the quality of support. We're having yet another consultation about that. There is so much evidence that's been written, that's been spoken about, and yet another consultation has been funded, and it looks like we're unlikely to get even some draft new practice standards until the end of the year. So it's been a long, slow process with very little action to improve the quality and to counter some of the issues that have been happening externally. But I think even though external issues are really important, we need to think about what organisations can do at the moment to improve the quality of support. And what we see in our data is this enormous variability between organisations. So the highest performing organisations in our study are living in the same environment as the lowest performing organisations, and yet they're managing to do so much better. So you can see from this graph, the average score on the active support measure in the highest performing organisations is 67, with 57 for people with high support needs and 75 for people with low support needs. And the lowest performing organisation has an average of 28, with 24 and 45. That's a huge difference between those two organisations that are subject to the same external operating environments. So I think there's a lot to be learned from understanding how you can go against the trend of this declining quality. And we can do that by looking at some of the organisations that are in our study who have managed to go against that trend. And I just want to very briefly talk about one organisation which had a very strategic approach, had a really clear strategy plan for improving the quality of practice, and over a period of 2 years was able to see a statistically significant increase in the quality of support in their organisation. They invested in training of all staff in active support and in practice leadership. They reshaped the expectations that they had of their frontline managers so that their core purpose was to do practice leadership. And they instituted ways of supporting practice leaders in their task of supporting direct support workers. So practice leaders were regularly mentored and supervised and worked together as peers in a community of practice. The thing that stood out in this organisation was that there was strong leadership at the senior level amongst a group of people that were very knowledgeable about practice. So there were not only good intentions, but they had the knowledge about practice in the senior levels of the organisation in order to support the implementation of that change and of monitoring and supporting good practice. And of course, it was endorsed, the strategy was endorsed by the board, so the support was coming right from the top of the organisation. And importantly, they put in place key performance indicators for practice quality and the tasks of frontline practice leadership, so that there was accountability for quality and for those practice leadership tasks, as well as for compliance with all the external compliance requirements. So it meant those things were monitored regularly and are seen to have equal importance to some of the other compliance issues. So just to finish off, what we've seen since 2013 is decreasing quality of support for people with intellectual disabilities who are living in group homes in the context of a very individualised funding system and increased overall funding for the disability sector. People with the highest support needs are continuing to receive the poorest quality of support, and that quality of support is fast diminishing. So we need to think about how do we address this issue? How can we counteract this race to the bottom, as somebody said? I think it's really important that we start to think about differentiating people with intellectual disabilities, particularly those in group homes, from other NDIS participants, and think about targeting the quality of support, the quality of everyday support for this group that makes the difference to their quality of life and their level of engagement. They need to have less fragmented services and more wraparound services with more skilled staff. They don't have the capacity necessarily to self-direct, and they don't often have strong family members to do that self-direction and monitoring for them. So we do need to separate them out and treat them as a separate group that have a separate set of needs for whom quality support is fundamental to their quality of life. And we need to focus not just on stopping bad things from happening, which I think has become the mantra of our regulatory system. We need to think about making good things happen, quality support, rather than stopping bad things from happening. Because if we make good things happening, the bad things won't happen. We need to think more about it's not just more staff, it's not just smaller services. It's much more to do with the skills of those staff. And I think there's a lot to learn from the organisations that are going against the trend and are able to sustain quality support. And those are marked by investment in training and skilled support workers. And we know from other analysis that we've recently done, which is that if staff are trained, if staff are providing good quality support, then they're likely to be more satisfied. And if they're more satisfied, there's likely to be less turnover. If there's less turnover, that's going to be a cost saving for organisations, but it's also going to have an impact on the quality of the support that's provided. So it's a virtuous circle if you invest in training and skilled support workers. And some organisations are still investing in those things. They're investing in practice leadership, support for practice leaders, and for KPIs, as well as thinking about administration and compliance. But I guess the major concern that's on everybody's lips is, can they sustain it in this current climate? Will the NDIS and its pricing structures and its organisational approach to people living in group homes, is that going to be able to support organisations who are continuing to invest in quality support, or is it just going to gradually erode the efforts that organisations are making? So I'm going to leave that there, and we'll have some discussion.
Thanks so much, Chris. A good presentation, in my view, is one which is evidence-based, is stimulating and indeed provocative. And your presentation meets all those criteria. If you are a participant in the seminar and would like to ask a question of Chris, please pop your question into the press on the Q&A button in your Zoom toolbar and then pop your question in there. And we've got one comment in already. But Chris, a couple of questions from me before we go to that comment. Firstly, a technical question about the figure on that of group home residents, some 39% have intellectual disability. Is that intellectual disability is their primary disability, or is that intellectual disability as part of the mix for those people who have multiple impairments?
It's a really good question, Alan, and I wish I had the answer. You know, we're reliant on the data that is produced by the NDIS in the quarterly reports, and it's more or less based on the primary disability that is recorded for somebody. So I suspect that the proportion of people with intellectual disabilities is much higher than that, because many people with intellectual disabilities have autism as well. And for some of those people, autism is recorded as their primary disability. Some people have Down syndrome, and that's recorded separately, but I tend to count them together. And some people have multiple disabilities or cerebral palsy, and they're counted by that. So they didn't set up a good data system in terms of impairment groups, because that was sort of ideologically, I think, against the way in which the NDIS wanted to operate. It didn't want to put people into impairment groups, so it didn't pay a lot of attention to that. I suspect that's going to change. in the way that then they'll be collecting data and the way they're now giving impairment notices to people and being much clearer about what people's sort of impairments are. So yeah, I suspect the number is greater.
Thank you. I'm going to ask a question which I suspect is on the lips of any advocates who are joining the presentation this afternoon. And I know you've tackled this question in part already, but I'm going to ask it anyway, Chris. Isn't the real problem that the group home model is fundamentally flawed, and anything you attempt to do that is really just trying to plug holes in a bucket?
Oh, no, it's not. The real problem is not the model of support. If the real problem was the model of support, we wouldn't have so much variability in the quality of support and the quality of life of people that are living in group homes. There is enormous variability, if you look at that last slide, between one group homes where they are getting really good outcomes and providing really good quality support and the ones that aren't. The problem is the quality of training, practice leadership, and senior management endorsement of that. It's the focus on quality that's the problem rather than the model. It used to be there were too many people, the number of people are getting less. Now, that's not to say that if we had some research about some of the more individualised options, we would be able to compare the two. But we did some research a number of years ago before the NDIS that compared people with similar characteristics who were living in group homes to people that were living with drop-in support, either on their own or with another person. And the quality of life of those people was pretty similar. It was pretty mediocre because the people that were living on their own were incredibly lonely. They had a bit more choice in their lives, but they didn't have choice about staff, and they were very socially isolated. So living on your own or living in individualised settings is not necessarily the answer, particularly for people with high support needs or people who have no good, strong social networks.
Thanks, Chris. And Chris, I might ask you to stop sharing your screen.
Yeah,
So
all
we can
right.
have
I
a
would
better picture
like
of you. Thank you. We've got a few
Have I
questions.
done that? No.
No, not yet.
Has it done it now?
Sometimes there's a little bit of a lag, but if you hit, there should be a stop sharing. There you go. That's the problem, the lag. So Tony Tregale makes a comment, and when you were talking about poor quality care, Tony's comment was that it's in poor quality care, you sometimes see minder care, that the focus is on minding individuals by staff and appearance employment. And that's the culture in these bad environments. Do you
Yeah.
have any observations about that?
I think I mean, I would agree that if you're not well trained and you're not well supported as a direct support worker, then you're running a hotel for people. You're basically caring for people, cooking for them, cleaning for them, doing things for them, and you're not supporting their engagement. And that's what happens if you don't have well trained staff that are supported and have a clear sense of what they should be doing. Yeah, we see, staff that are their main aim is to, as they say sometimes, keep the lid on things, just make sure everybody's sort of happy, sitting unengaged, not causing any trouble. That's a real problem.
Absolutely. And Carla's Seaman asks, hi, Christine, thank you for your presentation. How was the quality of support measured? So could you talk through the technical measurement of that, please?
So we measure the quality of support, first of all, doing a 2-hour observation of the person being supported, and we measure on every minute whether that person is engaged and if they're engaged in what sort of activity they're engaged in and whether they're in contact or staff are in contact with them, whether staff are giving them assistance. So that gives us that data about levels of engagement and types of activities. And then at the end of that 2 hours, we use the ASM, which is the active support measure, which has 18 items from memory, to make an assessment of the quality of support. So it's based on observation from a very skilled researcher. It's not based on self-report or staff self-report, which obviously tends to be much more positive. So it's a measure that's been used. It was created in the UK in 2005, I think, and it's been used consistently to measure support over this time.
Thank you. And Bo asks, is there an explanation why there was a steeper drop in the quality in allocating and organising staff compared to the other frontline practice leadership tasks? And Bo acknowledges that all tasks have reduced across time, but why the bigger drop in allocating and organising staff, do you think?
I can only speculate. I don't have a lot of evidence for that. But what we often hear from staff is that we don't need to organise the shift because we know what we're doing. We just come in and we work together and make it up as we go along. And so staff are fairly reluctant sometimes to do shift planning, even though it's really fundamental. So there's that sort of reluctance, and with increasingly that's problematic because of the staff turnover. So the staff coming in don't necessarily know the people that they're supporting and aren't familiar with the house routines. And it's probably, I think all the tasks of practice leadership require a lot of skill and knowledge about active support and about supervision and mentoring and observation of practice. And the organising the shift is probably one of the most sort of technical aspects of it. And what we're seeing is lots of organisations experimenting with different ways of doing that, and different technologies. So the technology is changing. Some organisations are trying to get it into smartphones and into the sort of electronic systems rather than paper-based systems or whiteboards with shift plans. So I think it's one of those things that's in a bit of a state of flux, and it's pretty challenging.
Thank you. And Woody Wheely asked, what measurable data collection methods or assessments are feasible on a shift per day support basis? Also goes on, how can we assess what quality and safe and effective is to the person being supported, noting that varies by individual?
Two things. So I don't think you should be trying to measure the quality of support that staff are doing on every shift. You should have a very strong expectation that staff are doing good support. They should be trained to do that and supported to do that by frontline managers. And frontline managers should be regularly observing staff, and observation is the best method of judging the quality of support. So I think often organisations are spending too much time trying to get staff to record things, and we know that staff recording and paperwork isn't a good representation of quality. So I don't think we should be too obsessed with measuring as we go. Increasingly, there's external organisations like us that will come in and do that sort of benchmarking. But there's also a tool, the OPQ, that we've talked about at the end of last year, which is can be used by internal audit personnel to come in and do a sort of snapshot of the quality of support that's being provided by staff. So it's not something you need to be measuring every day, but it's something you need to measure intermittently. But you need to be skilled and know what it is you're measuring, and use observation rather than paperwork. And there was another question.
So about the quality being dependent on the individual. Well,
yeah, so there's years and years of research that suggests that if people are engaged in meaningful activities or social relationships which are based on their preferences and their choosing, then they are likely to have a much better quality of life. And we're talking predominantly about people with high support needs, and the way in which you try and understand what it is they enjoy most and what are the opportunities that you offer them is by offering those and trying and seeing it, not by offering abstract ideas, but by offering very concrete opportunities to be engaged and then watching and working out what that person's preferences are. So I think we have to stop the mindset that you just have to ask people, because there are some people that won't understand what you're asking and won't be able to respond. But if you offer people alternatives, then they will be able to express their preferences.
And Elizabeth asks a great question. She wants to know, how can families find out who are the high-performing services?
I think that's a really good question. And I think over time, I think that's why getting some really good practice standards in place and requiring organisations to report against those practice standards using observational methods, using some consistency of measures, will be a way of having, in effect, a league table based on some evidence about the quality of support of different organisations. Because at the moment we're in a market and you're dependent on the marketing people telling you what good people they are. The organisations that are in our study know that they're in our study. They've got data about their services. There's nothing to stop them sharing that and advertising what their scores are. So there is some data available, but it's confidential to each of those organisations at the moment.
Thank you. And Jennifer Clegg is joining us as well, I presume, all the way from the UK. Jennifer's question is quite long, but it's a really interesting one. Jennifer states, I've been reading the 3 volumes of the Voices of People with Disability. That is the volume, 3 parts of volume 1 of the Disability Royal Commission report. And Jennifer says one striking issue is the vastly differing ways people describe their person with intellectual disability, which appears to be an expression of current identity politics. So Jennifer's question is, how do you think the conversation about de-differentiation and group solidarity can start to change this culture? Oh, there's a lot in that question. I'll leave it to you.
I don't have a simple answer to that, I'm afraid, Jennifer. I think the important thing is that if you look at those three parts of Volume 1 of the Royal Commission, they cover very different time periods. You know, they stretch from people's sort of memories of institutions and the early days of institutionalisation right up till now, and the language has changed so significantly. When I started in disability services, we had the Office of Intellectual Disability Services that was very separate and very clear about the group of people that they were supporting, even though that is a very diverse group. And I think the language has just been moving consistently since that time, since we moved to talking about all people with disabilities. And if you look at other parts of the Royal Commission, they talk about people with high complex needs, people with severe communication difficulties, people with all sorts of different names that are being applied. And I quite honestly don't know how, other than putting out position statements and advocating for more consistency, it's very hard in the current climate to join in that sort of discussion about getting some really good, consistent descriptions of people at a time when it's not okay to talk about people's deficits, and yet it's very easy to talk about the good things and the personalities of people with profound intellectual disabilities. But in order to really understand those people, you do need to understand some of their deficits as well. So that using descriptions that are deficit-based is seen to be something that you can't do, but it's very hard to convey who you're talking about unless you have some descriptors of what people can and can't do. So I don't think there's any easy answers to that, as Jennifer knows.
We've got 5 questions remaining. I suspect we won't have time to get through them all, but we'll give it a go. So an anonymous attendee asks, given your observation that the successful services have proactive senior management, good knowledge of active support, would you support some kind of mandatory training for such senior management?
Oh, yes, I didn't pay you to ask that question. I think that's really important. And one of the organisations that's in our study, I did a masterclass with the very senior managers in their disability services. And it was so useful because they were using different languages, they had different understanding of active support, and most of it was very superficial. They all knew it was important, but they didn't actually know what it was. They couldn't talk about it, they couldn't critique it, they couldn't give feedback to staff. So, and increasingly we're getting people into management, senior management positions in disability services that haven't worked their way up from being disability support workers, that haven't come from the sector, come from places like health or insurance or goodness knows what. And those people need to have a really firm grasp of what good practice is, what it looks like, and how to give feedback to direct support workers around it. So yeah, I think it should be mandatory. In the UK, they have registered managers, and I think that could be part of our new standards, that we would have managers, frontline managers who would registered, who had a set of competencies and qualifications, and similarly for more senior managers.
And Virginia asked a number of questions picking up on the role of support coordinators. Have you got any hints about how support coordinators can determine a good cell provider?
So if you look on our website or on my list of publications, there is a number of guides to good group homes, what to look for, what to talk about. Those are freely available, which give you a set of things to look for and to ask staff about. And there's also the OPQ, which is the Observing Practice Quality, which as a support coordinator, if you're making decisions about services, there's no reason why you couldn't become familiar with that and do some of your own observations and make judgments. I think that might start to, get some of the not so good providers to pay attention to quality if support coordinators were in a position to be distinguishing between good quality and poorer quality.
So this will have to be the last question, unfortunately, in view of the time. Without naming names, was there any difference in results between former government homes, which have been transferred to new not-for-profit providers, versus new entrant organisations?
That's a very difficult question. The only thing I can say, I think at this point, and we are going to do an analysis of now we've got a data set that includes a large number of the transferred services. For the first time, we've got that big data set. We're going to compare those to the non-transferred services, but we did that within one organisation and there wasn't any difference. So I don't know. I think that's the question. We will know when we've done that analysis, but we don't know at the moment. Okay, welcome back. And it's my great pleasure now to introduce Adjunct Professor Alan Hough, who is going to talk about a paper that is currently under review about federal cases where there's been harm to people with intellectual disabilities and what you can learn from those three federal cases. So over to you, Alan.
Thanks, Chris. So my co-authors on the paper and equal partners in the research were Chris and also Dr. Drew Marsh. I need to acknowledge up front that this is going to be a very difficult presentation. We are looking at the circumstances of 3 deaths of people with intellectual disabilities during the course of service provision. The families and friends of the individuals who've died will undoubtedly be traumatised. The workers and indeed the managers who are involved in some of these incidents would also be traumatised. If you find that you are being triggered by the material, my suggestion is simply to shut down your system for a few moments and go for a walk, focus on a nice flower or plant in the garden, something like that, or get out your dog and give the dog a hug. So the 3 cases are proceedings by the NDIS Quality and Safeguards Commission against the Australian Foundation for Disability, otherwise known as AFFORD. against Live Better Services Limited, and also against Valmar Support Services Limited. The material we drew on were the actual statements for reasons by the judges, and also the statement of agreed facts appended to those reasons. For a Ford, we also had access to the materials which were before the Disability Royal Commission in their public hearing 23, which focused mainly on a Ford's Day programs, but also touched on the organisation's response to the death of Myrna Apram, which is one of the cases we will be looking at. I need to mention that all three cases occurred under the respective organisation's former management, not their current management. I also need to make a disclaimer that in terms of drawing on the agreed facts, these are agreed between the NDIS Commission and the provider concerned. They're not necessarily agreed by the workers involved. So anything that I say is a fact, please keep in mind it might not be a fact from the perspective of the workers involved. In relation to the materials before the federal court, we have applied to the court on a number of occasions for access to the documents. The court has been willing to release the formal documents, not including witness statements. And so that is one of the limitations of our study. So the first case we're examining is the death of the young woman pictured, Myrna Apram. And what I'm going to do in talking through these cases is draw on the actual judgments of the court in some cases. So please bear with me whilst I read. Her Honour Justice Abraham wrote in her decision in this matter that on the 23rd of May 2019, 20-year-old Miss Myrna Apram drowned in a bathtub while in the care of a Ford. Miss Apram had been diagnosed with epilepsy, autism spectrum disorder, and moderate to severe intellectual disability as a child. At the time of her death, she was residing at a group home for persons with disabilities operated by a Ford at Woodbine, New South Wales. There were two other residents of the home and two staff members on duty on the evening of her death. Neither of the staff members knew that Miss Apram had epilepsy or suffered from seizures. And I interposed to say, but the organisation knew this. But neither of the staff members knew that Miss Apram had epilepsy or suffered from seizures. Neither had worked at Woodbine before, and neither had completed a buddy shift at that home prior to the events in question. Miss Apram was left in a bathroom of the Woodbine property unsupervised for approximately 25 minutes. Miss Apram was able to lock herself in the bathroom. When the Ford staff returned to the bathroom and it became clear that she was not responding, they were unable to unlock the bathroom door from the outside. They ultimately gained access to the bathroom by using a knife from the kitchen to dismantle the door handle. So that's the end of the quote from the judgment. It's important to note that the issue in a Ford was not the absence of organisational policies and procedures or plans, but rather that they were incomplete or they were not fully implemented. The penalty imposed by the court in relation to the risks which led to Miss Apram's death totaled $400,000. $222,000 of that penalty was for a Ford's unsafe practice, that is, for failing to prevent Myrna from drowning. $180,000 was for the unsafe environment, that is, having a bathroom door which could be locked internally. The second case we're examining is Live Better, the organisation Live Better, for the failures that led to the death of its client, Kaya Lucas. And Her Honour Justice Raper of the Federal Court wrote in her decision in this matter that on the 2nd of February 22, Ms. Lucas sustained burns to 35 to 40% of her body whilst receiving bathing supports from Live Better. And I note that this was bathing supports in her family's home, not a group home. To continue quoting from the judgment, tragically, 5 days after sustaining the burns, Ms. Lucas died. The medical records refer to her death as being caused by burns. Miss Lucas had Cornelia de Lange syndrome and other disabilities and health conditions which Live Better were aware of at all relevant times. She was small in stature, unable to independently mobilise herself, and non-verbal, but could be vocal. Miss Lucas also suffered from profound intellectual disability. I won't quote further from the judgment, but I will note that Ms. Kaya had only started receiving bathing supports in the family home from the organisation in April 2021, but she'd been a client of the organisation since at least 2009. Those bathing supports had been provided on 80 previous occasions without incident. It was on the 81st occasion that the water was too hot. The two workers providing support did not notice that the water temperature regulator had been set at a higher temperature than usual. Indeed, one of the workers had checked the water temperature with her own hand in one part of the bath and had considered it safe for Kaya to go into the bath. It was only in response to Kaya's vocalisations and behaviours once she was in the bath that the workers realised something was wrong and terribly wrong. The entire incident that ultimately resulted in Kaya's death lasted between 1 and 2 minutes. I find that fact particularly chilling. The penalty imposed by the court in this case reflected a much more active approach by the NDIS Commission in terms of the seeking of penalties. So the agreed penalty imposed by the court was $1.8 million. Of that $1.8 million, $644,000 was in relation to the failure to train workers adequately. The organisation had done some training, but the parties admitted that it was not adequate. Another $644,000 of the penalty was due to the failure of the organisation to assess worker competency, and we'll come back to that issue in a moment. Our last of the three cases concerns proceedings against Valmar Support Services, and in this case the identity of the men was not disclosed by the court, and hence I do not have a photograph to honour the deceased. But the court referred to the three men as Mr. H, Mr. K and Mr. I, and it was Mr. H who died. This case was also heard by Her Honour Justice Raper, who wrote that in the period between February 2016 and May 2020, the respondent, Valmar Support Services Limited, operated a residential group home. Three participants, Mr. H, Mr. K and Mr. I, being men in their 40s, resided there. Each of the residents had intellectual disabilities and were known by Valmar to be at risk of harm by choking when they consumed food or drink. Despite this, none of the support workers who attended to their care had any formal training with respect to that risk. On many occasions, Valmar exposed or increased the risk that the residents would choke on their food. On the 14th of May 2020, a terrible event occurred. Mr. H choked and collapsed while eating food that had been prepared for him and where the management plan meant to ensure his safety was not complied with. Mr. H died 3 days later. The cause of his death was recorded to be choking on food. Justice Raper was highly critical of the organisation's failure to train any of its workers about the critical risk food posed to the 3 clients. Undoubtedly, they had other training, but not in relation to this risk. Verona commented, the gravamen of the contravening conduct, that is the seriousness of that conduct, was the failure by Baumar to train its employees at all as to how to safely feed these men with known risks of choking. It is not a case where there was some but inadequate training undertaken. Rather, none at all. There is no explanation for this. Verona said, there cannot be. The civil penalty imposed in this matter was over $1.9 million. That had been agreed by the parties. It's important to note that Verona obviously, it's clear from the judgment, almost rejected that figure as being too low. But she ultimately did agree to the amount negotiated between the 2 parties. Of that $1.9 million, just over $1 million was in relation to the failure to train the 13 workers involved in the support of the 3 gentlemen in how to provide that support safely. So all 3 cases are shocking and disturbing. I now want to move to how we've dealt with our analysis of the cases. So we looked at the cases in terms of what occurred in each individual case. So we thought about analysis within the case. We also thought about analysis across the 3 cases, what elements might have been in common, what were different. And we also engaged in what's called beyond case analysis. And we used 3 academic publications and 1 newspaper article as our points of comparison. I've included that level of detail for anybody who wants to follow up those articles after the after today. And just to repeat that these slides will be made available when the video is released and on the LIDS website. Our focus in the research was, well, on the processes of quality and safeguarding and the failures in those processes. And in particular, we wanted to break the processes down, what's known in the academic literature as the micro processes. Another way of saying this is the common phrase, the devil is in the detail. And we will see absolutely that it is these fine processes, micro processes, with which, if providers get them wrong, can have very serious consequences. Now, all up, we identified 13 lessons for practice. Time prevents me from working through all of those in detail, so I'm going to choose one in each category and talk it through whilst acknowledging the other lessons. So in relation to risk assessment and management, the item I'm going to focus on is sublesson 1.1, ensure effective processes to assess and control risks. And stark failures in risk assessment and client planning were clearly evident in all the 3 cases. In relation to Afford, organisationally, Afford held information that Myrna could experience seizures whilst bathing, but sharing that information was problematic on several counts. There was confusion of the date of her most recent seizure, recency being a predictor of likely next seizure. Her epilepsy management plan and comprehensive health assessment program plan were incomplete in important respects, according to the judgment. The client database did not refer to Myrna's epilepsy in either in her own records in either the disabilities or the diagnosis section of that database, and the section of the database which referred to the epilepsy or seizure management plan was also blank. Going to Live Better, the client plans in respect of Kaya were either dated or incomplete. As the parties agreed before the court, none of those risk assessments identified or considered risks arising from the provision of bathing supports to Ms. Lucas. Remember, she had been a client of the organisation since 2009. Bathing was only introduced in recent years. In Valmar, plans about clients' food safety were available to the frontline workers, but they were not implemented, and the court was critical of Valmar's failure to audit or supervise compliance with the relevant plans. Furthermore, there was little guidance to workers about food-related risks, with the court finding, with the parties acknowledging that there was no menu plan or shopping plan in place, despite workers requesting one, which limited the workers' abilities to provide the meals to the three gentlemen, which was safe. Now, assuring compliance is a consistent challenge in compliance management, and it's obviously insufficient to have policies and plans. You must have policies and plans which are then implemented. The only way to know if the plans are being implemented is to audit or otherwise supervise compliance with them. In relation to audit, Valmar's annual report the year before the incident stated that internal audits were completed for 46 services, and their external quality audit was completed at the end of that year. Clearly, neither the internal nor external audit processes were sufficient to detect and mitigate those critical risks to the three gentlemen, and it would be interesting to know whether they were more focused on the existence of paperwork than the actual practice. Now, the other lessons we've identified under this heading are it's important to assess and mitigate risks about new clients or new services to existing clients. So that's a particular source of risk, which is important. That it's important for providers to ensure risks concerning the physical environment are assessed and controlled, such as the fact that in the Woodbine Group home for a Ford, the bathroom door could be locked from the inside. That it's important for providers to seek professional advice about risks where needed and to ensure the currency of that information. And finally, it's important for providers to ensure information flows to those who need it and that it flows accurately. So in the case of a Ford, it being acknowledged by the parties before the court that the two workers on shift that evening were not aware of this critical risk to murder. Our second category of lessons for practice relate to staff learning and development. And I'll pick up the first one, which is obviously providers need to ensure that there is quality staff learning and development, but also to note that this needs to be tailored to the circumstances of individual clients. So a Ford's procedures required workers supporting clients for the first time to have worked a buddy shift, which is one strategy for learning and development. But this had not occurred for the two workers on duty of the evening that Miss Apram died, and the associated buddy checklist, so one existed, was not completed. In Live Better, two deficiencies in training were identified. First, not all workers supporting Kaya had completed required training. One of the 7 had not completed training in the personal care e-learning course, and 4 out of 7 had not completed the disability services e-learning. Second, the training they had completed was very general. And so a quiz in the personal care e-learning module asked the question, true or false, you should ask or gently assist your client to test the water temperature on the back and palm of their hand before entering the shower or bath. Now, that's probably what most of us did this morning or last night whenever we had our shower or bath. We tested the temperature with our hand. But in the case of Kaya, because of her unique condition, the Cornelia-de Lange syndrome, the answer true was not appropriate for her. For all these reasons, Live Better was found to have failed to train its workers appropriately. And in Valmar, as we previously noted, the court was scathing about the organisation's failure to train the workers about the relevant risk to the 3 residents. So the other lessons under this category are the importance of providers training staff in emergency response. In Afford, the workers did not contact emergency services. I think it was for 22 minutes after they first realised that Myrna was non-responsive. And also, it's important for providers to assure staff competency, as was highlighted in the Live Better case. In relation to our third category of lessons about role and task clarity, I'm going to pick up the first one, which is the obvious point about ensuring staff role clarity and staff task clarity. The agreed facts in the forward stated that there was an ambiguity of responsibility for collecting and storing of information. Now, I don't know from the documentation what this relates to, but it could be that it relates to the transition of client data from the intake function to the operations area, or it could be the transmission of this information between different parts of the operational function, or maybe it was between the frontline manager and the staff of the group home. Further, in an investigation commissioned by Afford, that investigation found there was confusion in responsibilities of staff on shift, as one of the workers rostered on the evening of the incident believed she was delivering one-on-one support to one particular client and not supporting all clients in the group home, and hence that worker did not read any of the background documents in relation to Myrna. This again demonstrates the importance of task and role clarity. So a range of strategies are needed to ensure staff role and task clarity. Organisational procedures must address the classic questions of who, what, when, where, and how. They can't be generalised statements that things will be done. They must actually clarify those questions, in my view. Second, we know from the healthcare sector and the disability sector that any point of handover of a client from one part of an organisation to another, or indeed in shift handovers in the same team, must be recognised as a point of system vulnerability with risk management implemented. Third, shift plans should specify what is achieved for and with the client on a particular shift, as Chris mentioned in her earlier presentation. So the other lesson we identified under this heading was the importance of support and supervising staff, especially those supporting a person for the first time. Lesson 4 is, there's a single lesson in this category, and that is the category is about implementing policies and procedures. And it's important to both have suitable policies and procedures, but then providers must ensure those policies and procedures are implemented. In Afford, the court stated that Afford submissions reflect a number of aspects of the policy and procedure framework were not followed or complied with. In Live Better, in response to the fatality, the provider published 3 additional procedural documents about providing bathing supports. There was evidence received. This was evidence received in mitigation, but it could also be construed as evidence of culpability. We note that the relationship between the amount of information that is provided to workers, such as policies, procedures, and plans, and the usefulness of that information from a frontline worker's perspective is likely to have this sort of shape. If too little information is provided, then the worker will not have guidance on how to act. So that is not useful for them. But if too much information is provided, let us think about, 80-page behaviour support plans, then that's not terribly useful for a new worker arriving to work for somebody for the first time either. So this point about usefulness of information is an important one for providers to consider, and I fully acknowledge it's not an easy balance to get right. So that's one of the challenges. The other challenge is, if the information is provided, will it be used? Now, we're not, in relation to Myrna's case, we're not suggesting that the workers involved in Myrna's support on the evening she passed would not have used the information had it been available and their role been clear. But we note other cases where information was available to frontline workers and was allegedly not used. Now, in some cases, the failure to read essential information might be due to negligence on the part of the worker. In other cases, it might be due to information overload for which the provider and the wider service system are responsible, or it could be a combination of both. The last category is in relation to leadership focus, and I'm going to focus in on the first sub-lesson, which is about the importance of providers ensuring leadership focus is there on quality and safeguarding and not just growth. The other lesson in this category is that providers must ensure the leadership and management of quality and safeguarding as a discrete activity. But to focus on the first point, all three organisations have experienced significant growth, with increases in revenue from 2014 to the year of the client's death of over 100% in Afford, and they were already a very large organisation. In Live Better, it was over 400%, and in Valmar, it was almost 275% growth. Now, we're not asserting that these rates of growth were atypical of NDIS providers during those periods. However, as the DRC asserted the Disability Royal Commission asserted in respect of Afford, growth may be a distraction of scarce managerial attention. And for example, Afford opened 19 new group homes and recorded a 35% increase in the revenue in the financial year in which Myrna died. Issues about Afford's leadership and organisational culture were identified by the Disability Royal Commission, which stated that under its previous management, interposed to stress under its previous management, not its current management, the Afford board and executive management pursued a strategy of significant organisational growth. The manner in which this strategy was pursued contributed to an organisational culture focused on growth and financial matters at the expense of safety and quality of client services. During its inquiry, the DRC identified that 2 months following Ms. Myrna's death, the then CEO reported to the board, all in all, a very good year. An apparent reference to Afford's financial performance. He made no mention at all of Ms. Apram's death or of any action taken or even suggested in response. The DRC found in what was the strongest criticism of any CEO of a disability service provider, and here I quote, "The former CEO approached his role in a narcissistic and single-minded manner, entirely inappropriate for a not-for-profit organisation delivering services to people with disability." So they are our 13 lessons that we have identified. In the remaining time, I just want to acknowledge some limitations of our research and also want to raise a couple of issues about how we conceptualise what needs to be done to achieve quality and safeguarding, and also some suggestions of new concepts to pursue. Now, the obvious limitation of this research is that it concerns 3 cases only, but of course these are incredibly important cases to learn from where people have been harmed. So that limitation is acknowledged, but is inevitable. The other limitation is that our understanding of the cases is limited to what's available to us in the judgment statements of agreed facts and transcripts and things that the court was willing to release. We did not have access to the statements of evidence. And this limits our ability to really understand what went on. And to use the classic words of Clifford Geertz, the best case studies are those where there is thick description. And so, although we obviously respect the court's decision as to what it will release to non-parties in these cases, it does limit our ability to understand what has gone on. In relation to implications for theory and research, there's 5 that we've identified, and I'm just going to pick up on 2 before I hand over to Chris for questions and answers. So we believe that practice leadership needs to incorporate risk explicitly. At the moment, it incorporates that concept implicitly, but there is a case to incorporate risk explicitly. As Chris has mentioned in her presentation, we do have a concept of frontline practice leadership. But from these 3 cases, we probably need a concept of organisational practice leadership as well. We need deeper systemic analysis. The nature of court proceedings is it focuses on fault by the provider without looking at the wider service system. And particularly in relation to in relation to Valmar, there's some very interesting questions which we don't know the answers to about the role of other parties in that case. We need to integrate lessons about harm and lessons for good practice. For those of you familiar with work health and safety literature, we need both safety 1 and safety 2 perspectives. And finally, we need to better understand frontline work and frontline workers' experiences. So I just want to pick up the first question, which is about the need to understand for practice leadership to explicitly incorporate concepts of risk. Strong frontline practice leadership clearly has the potential not only to eliminate risk or at least minimise risk, but also to ensure an understanding of good quality and safe practice, what it looks like and how it's going to be achieved and monitored. We note, however, that the existing explanations of practice leadership do not explicitly mention identification of risk or risk management. Rather, its lens is on the quality of support, and its logic is that the risk identification and harm minimisation are inherently part of, rather than separate to, delivering high quality support. But there is a case to explicitly incorporate practice leadership in the risk in the description of practice leadership. Now, to pick up the second point, to complement frontline practice leadership, a new concept of organisational practice leadership we believe is also needed. And this will embrace the lessons we identified under lesson 5. What should be in this concept? Well, that's beyond the scope of our current research, but it might be informed by Chris's preliminary analysis in one of the chapters in the book we co-edited. It needs to incorporate some lessons from clinical governance in the healthcare system. It needs to have regard to the duties of employers under work health and safety legislation, which of course applies not just to workers, but anyone in the workplace, and that includes clients. And finally, it needs to embrace notions of implementation science in the human services sector. And as always, I mentioned that I love the book by Fixon and colleagues on implementation science. However, we make the point that the development of this concept of organisational practice leadership should not simply involve aggregating suggestions from a whole range of sources in order to come up with an exhaustive and exhausting list of tasks. It needs to be empirically grounded. So by way of conclusion, it is, of course, hearing about these cases is deeply disturbing. Often when I talk about these cases in public settings, I tear up because they're just so sad. But the lessons must be learned by the service provider system. And we must understand that it's not about making, publishing policies and procedures, though they are important. It's about understanding the micro processes of quality and safe support and how they connect. It truly is the case, in my view, that the devil is in the detail.
Thank you, Alan. That was really, really deeply disturbing, but deeply interesting, hopefully, to people that aren't as familiar with those cases. So thank you very much. If you've got questions or comments, please put them in the chat. I've got two questions to start with. The one which just occurred to me at the beginning is these were the first three of the sort of formal cases that have been brought by the Quality and Safeguarding Commission. Do you have any sense of, are they different, more frequent, more severe than the cases in the past and before the NDIS?
No. If we think back to deaths by choking as a result of serving unsafe food, this was a consistent problem. It was identified by the New South Wales Ombudsman in their reports in relation to the deaths of people with disability in New South Wales. So I don't think it's the case that these problems are worse. It's just that they are getting the attention they deserve.
And they're national now, so all the information will be in one place going forward rather than in different states
Yes.
and different sort of bodies.
But I do note the point that the compulsory reporting is only in relation to service provision, that is by providers to NDIS participants. If the harm is caused or perhaps contributed to by the National Disability Insurance Agency and its decision making, then there's no reporting of that. That's an area in which the system is silent.
So they're not directly responsible for underfunding, although one could argue that in these cases funding wasn't necessarily an issue, but going forward. I might just note that it seems that the price review has just come out, which somebody put on LinkedIn saying it was gloom and doom and there's no increase for service support coordinators and there's minimal increases elsewhere. So, I think that's an ongoing issue. Anyway, one of the other questions I wanted to ask you was, as Bill Shorten was leaving office, he did a number of public sort of speeches about the fact that the penalties for harming workers were greater than the penalties for harming people with disabilities, and there needed to be change in the sort of regulatory system to increase the penalties so they were equal or greater for harming people with disabilities. Is that actually the case?
So it's how you interpret the words. So the maximum penalties under the work health and safety legislation are greater than those under the NDIS legislation. The actual penalties, and I've done this research, I've looked at the statistics, the average penalty of the three cases decided in the federal court under the NDIS legislation are greater than the average penalty, even for the most serious category of offences under work health and safety legislation. So it's a very interesting issue to unpick. And I think some of the support for the increase in penalties is almost jingoistic.
And actually, people with disabilities are also can be subject to the health and safety legislation.
Yes.
They count as people in the workplace, don't they, as well?
And in the Live Better case, Live Better was subject to the civil penalty proceedings in the federal court under the NDIS legislation. They are now subject to criminal penalties in the New South Wales courts under the work health and safety legislation. They have pleaded guilty to breaches of the Work Health and Safety Act in relation to the death of Kaya. The sentencing hearing is coming up later in the year.
Okay, so that's really interesting. So we might see some other follow-on cases in other jurisdictions. There's some questions. Tony sort of says, can you define what you mean by harm? It's a word that we throw around a lot. What's your definition?
Obviously harm comes in a whole range, in a full spectrum, from the everyday discourtesies that many people with disabilities experience, right through to the cases we looked at today of deaths. Technically speaking, when there is a proceedings under the NDIS Act or prosecution under the Work Health and Safety Act, it's not because somebody has been, say, died. It's because the organisation has failed to address the risks that somebody might die. It's a technical legal point.
Okay. Lindsay asks, what happens to the money? Is it used directly to address systemic flaws in the NDIS for people who have been harmed, or more generally for participants, or where does the penalty money go?
My understanding, and I could be wrong about this, is that it goes to consolidated revenue. It does not go to the families of the person who's died. Presumably they will take actions for negligence and receive a monetary settlement as a result of that.
So there's no, yeah, okay. Emma says, do you believe that organisations, how do you think organisations can strike the balance between the volume of information and the level of detail needed to provide and deliver quality and safe services? And if so, are there examples of where this has been done exceptionally well? I'll hand that over to you and then I might have a chip in too.
So I posed the dilemma. I didn't actually offer a solution. I think one of the things which is important is actually to design the quality management system in conjunction with the workforce who are using it. But I'll be interested in your take on this, Chris.
So my argument would be that if you have really good shift plans that involve the sort of standard routines that people follow, recognizing that they can be flexible, but that's a sort of blueprint and backbone that you can then work with, that provides key information about who needs what support to do what during the day with the regular things that they do. So that can be really good information about the type of support people need, and that you can back that up with really clear, succinct one-page profiles that are accessible to staff, that again succinctly bring together the key information that you need to know about that person if you've never met them before and if there's nobody else on shift. So there are examples on our practice leadership training program, which is freely available online, of really good shift plans. And I think they provide the sort of the basis of what you need to provide, which is really succinct, clear evidence. And obviously somebody needs to hold some more deeper, more detailed knowledge. And again, that should be the role of the practice leader and the more experienced staff who can then share that verbally. But we need to be aware that many of the support workers now working in the system often don't have high literacy levels. They often come from non-English speaking backgrounds, and the information needs to be really clear and concise and not hidden away in layer upon layer of sort of electronic data. It needs to be clear, succinct, simply written, and accessible. And that will be.
And I would add the word, and it must be contemporary.
Oh, absolutely.
Yes.
It must be up to date. And I think that's one of the issues. How many times have we walked into group homes where there's a board that says, these are the staff that are on duty today, these are the people that live here. And unfortunately, somebody's left 2 weeks ago and those staff are no longer current, and somebody's moved out. So we're not good in group homes of keeping that information up to date. And I think that's one of the key things that was very evident in one of those cases. Okay, now this is a really hard one. So Milia says, where do you see implementation science, theories, frameworks and models being useful in this space, and for what purpose?
A great question. And if Miller would like to have a conversation out of session, please connect with me on LinkedIn. Firstly, I want to distinguish between implementation science as it's practiced in healthcare, and then implementation science as it's practiced in the human services, and hence my explicit reference to Fixon and colleagues' wonderful book. I need to acknowledge, though, that their work is focused on innovation, whereas what I'm really focused on is day-to-day business as usual service provision. So we can't assume that their concepts, which were developed in relation to innovation, are necessarily right for day-to-day business, but there is certainly an appealing logic. One of the things that they emphasize is the importance of implementation fidelity. That is, if you have a model of how you propose to deliver services, that you actually stick to that model, and you know that you're sticking to that model, and you resource that model to ensure that it is implemented. So one of the thoughts which has occurred to me across time is that perhaps for those providers which actually aspire well, have good aspirations, which perhaps have developed their practice model already, that their critical challenge is in fact about implementation fidelity. And that's where I think implementation science can help us.
Yeah, I think we've seen that. We've seen, very variable over time in the same organisation. There's a question from Wayne, who talks about, he thought there was some work being done on the cost to deliver quality support, and is just wondering what's happened to it. Is it there? Are we looking at that? I would say, before I give it to you, is that we need to be really clear that there isn't one cost to delivering quality of support. It depends who you're delivering quality of support to and what type of support, which comes back to differentiation and the need to think about different groups. But also the research from the UK, from Julie Beadle-Brown and her group, clearly says that the cost of delivering quality support is no greater than the cost of delivering really poor support. And I think that's something to bear in mind before we start looking at, are we getting paid enough money to do it? Over to you, Alan.
Though with so many of the organisations involved in your own study now operating in the red, and so many organisations now having active discussions that we've only got enough cash to survive a year or 2 years, and then we will have to shut the doors. It is a relevant point. So I'm not sure that there's academic research in this area that quite meets the gap that Wayne has identified. We do have the financial benchmarking study completed by National Disability Services in conjunction with Stuart Brown and the lovely Siobhan Simpson. We do have the very good work which is being done by Ability Roundtable, and it's pleasing to note that their work is now extending into quality benchmarking quite explicitly as well. And it will be interesting and exciting to watch that develop across time. but there's nothing I know that explicitly addresses the question of what does good quality support look like. What is clear is that what's in the NDIA pricing model is not designed to assist providers do anything more than essentially break even, provided all other assumptions they make in that model are maintained, or a 2% profit margin.
I think I think the thing is you need enough resources, and the enough is enough to provide either good or poor quality. It doesn't differ, but I think we seem to be getting to the stage where providers, particularly of group homes, don't have enough resources. That's the bottom line problem.
And you do need to have resources to implement trained staff in active support. You do need to have resources for frontline practice leadership, and the ratios of supervision in the NDIA pricing model. What is it now, 1 to 15? 15 full-time workers when the majority of workers in the sector are part-time. That's very questionable.
Just following on, one of your other lessons was about ensuring competence of workers, not only training, but that they've actually understood what you've trained them in and can put it into practice. Do you have some thoughts about that?
So this was a feature of the Live Better case, whereas we identified $644,000 of that penalty was in relation to the failure to assess workers' competency. Now, nowhere in the NDIS practice standards or the quality indicators does it explicitly state that a provider has to assess competency. That's the first point I'd make. Now, no doubt some quality managers in the audience will be going, oh yes, but it's in the high intensity personal skill descriptors. And yes, but that's not a legal document. In the same way that the practice standards, rules and quality indicators are. And when you go to the NDIA pricing model, that is not explicitly recognised. Now, I want to make the very important point that in principle, I absolutely agree that key competencies must be assessed. The challenge is knowing which of those competencies are key. There must be hundreds of competencies involved in frontline support workers. So which of those are key? And that's not always going to be obvious. And the second thing is that I don't believe anybody would suggest that the current NDIA pricing model recognises this. So essentially what we have, and again, I'm not criticising the need for competency assessment, but what we have, I think, can rightly be described as what academics call regulatory creep, the gradual expansion of expectations on the part of a regulator across time.
Okay, thank you. I think we should leave it there. Thank you, everybody, for your questions. If you want to contact us, you can do that through the LIDS website, the LIDS email. The slides will be available. The recording will be available within a week on our site. Hopefully you can find it. If you've got queries we'll pass them on to Alan. And if you want to have a link to the group home guide to good group homes, I can send that to people too, and try and put it nearer the front of the site. So thanks everybody very much. Thank you very much, Alan, for a very good session.